Right, good afternoon, everybody. For what could be our last COVID briefing, at least for a while, very hopeful. We got the band back together again. These are the folks that I really relied on over this last, 15 months. Of course, it's Josh and Deirdre and Paul, and backed by popular demand, Indra Nooyi and Albert Coe, who led our reopening committee. And, of course, Scott Gottlieb. And everybody always says, according to Scott Gottlieb, we've heard that a lot over this last year plus. Let me give you a quick update before I hand it over to the folks who really gave us the insights we needed. Very quickly, the numbers are where we want them to be. 1%, 7-day average, 1%, hospitalization, fatalities. Overall infections, 4 per 100,000. What does that mean? It means probably a 6th best in the country, thanks to you. Thanks to the fact that you've taken the lead, first when it came to masks and staying at home, and now when it comes to vaccinations. That's made an enormous difference. Let me tell you just a bit about the journey. I think you can see we were hit hard. We were hit early. You see where we were back in March, April, May. It was mid-April, I think, that Albert and Indra came on board when we had to start thinking about, number one, how do we keep people safe? And what should we be doing every day in the name of the public health? And we knew fundamentally that there was not this tension between health and the economy because we were not going to be able to have people with the confidence to get back to work until they were confident that we could do it safely. And Indra and Albert were really key is what we tried to do there. I think you can see we were low during the summer months where we did an awful lot of testing. And that meant that during that small winter surge that we had, you can see started picking up in October, really November, December. It picked up, no question about it. That yellow line is the percentage of positive tests. And there, I think because of track and trace, I think because of masking, because of some of the precautions we could, and then starting in mid-December with vaccinations, our yellow line, our infection positive, did not nearly ramp up as much as it did in the upper Midwest. You remember California, even the Sun Belt were hit particularly hard in that second wave. And thankfully, Connecticut, well, we did take a hit, not nearly as severe as a lot of our peers. I think we'll be able to talk a little bit about some of the decisions we made along that journey. But let me just move on to where we are today. I think you remember this map from 2 months ago. It was red. It was the measles map 3 months ago. And now I think you can see that we got 44 towns that have really zero infection at this point. One, I don't mean to single anybody out, but Putnam, you are the one, last red one, and I think that's going to be brief. I think you see a little bit of cases in southeast Connecticut. Along there, you'll see what that means. A little bit in the Naugatuck Valley, Waterbury, Hartford, but I think you see the trend lines give us a great deal of confidence that our reopening is okay. You maybe remember we started reopening on May 20th, you remember that last chart, and the rates kept going down for the next 5 months. So I think we've been able to do this cautiously, and we will do so again. Look at that map and then compare it in your mind to this map of Connecticut. The darker the blue, the more likely you are to be vaccinated. So I think you see along the shoreline communities there, up in the Northwest, Fairfield County, pretty high vaccination rates, in the 80s. I think, again, you can see in southeast Connecticut, we still have a little bit of work to do, down in the 30s and low 40s. This is important because you're going to hear from Albert and Scott Gottlieb in terms of what maybe we worry about as we look around the bend to this fall. One thing might be the possibility that if there are some areas that were less likely to get infected, you could see some flare-ups, especially with the variants. So that's why we are not taking our foot off the accelerator when it comes to getting everybody vaccinated. And I think you can see those few places where we still have some work to do. I broke it down by geography there in terms of vaccine. Here, I think the chart on the left shows you an idea by age, how people are getting vaccinated. My age group continues to be the champions, those over the age of 65, 93% vaccinated. I think the numbers speak for themselves. The 12 to 15-year-olds have ramped up quite a bit at 31%, for which I'm happy. Continuing 16 to 18, now at close to 60%, which is a lot more than the 18 to 34-year-olds. Still, that's a demographic we have to work on particularly hard. Drinks on us for another 4 or 5 days. Don't miss your opportunity. We spend a lot of time on equity, and I think we could have learned that even earlier. But I think what you see here is when it comes to vaccines, we still have some work to do. You can see if 59, almost 60% of all the Caucasians have had their first vaccine dose. That's 30%, 36% of African Americans, 41% of Hispanics. No false comfort in this, but that we are, number one in the country when it comes to Hispanics getting vaccinated. False comfort, we have a long way to go there. We could use your help as trusted resources. And when it comes to African Americans at only 36% vaccinated, that's number 6 in the country. But we still have a way to go there. So when it comes to those pockets where we still have some folks to be vaccinated, some of it's related to geography, a little bit related to age, and still some are related to ethnicity. And there we're going to work and continue to work and not take our eye off the ball until everybody who can be safely vaccinated is vaccinated. Look, with that, let me just kick things off by reintroducing 2 friends who I think you got to know pretty well over this last year plus. I certainly have. I've known Indra for many, many years, great friend of mine. I really wanted somebody with stature in the business community. We were closing some things down back there in March and April, and we had to have somebody who could explain what we were doing, why we were doing it, and how we were going to get things opened. And her wingman on this was Dr. Albert Coe. Albert Coe, as you know, a Yale School of Medicine, leading epidemiologist, the perfect guy to lead our scientific response going forward. And Albert reminded me when he got that sudden phone call from me, actually he was in the morgue at that day, checking out a young COVID victim. So the timing was right, and we definitely had his attention. So Indra and Albert, I know, Indra, you can't stay for too long, so why don't you kick things off? What do you remember about those times, and what could we learn from it?
I think that, first of all, thank you for inviting me today to speak with you, Governor. When you asked me to be part of this Reopen Connecticut Advisory Committee, I didn't know much about viruses. All that I knew was related to business and economy. It was dark days when Albert and I first met. It was very grim, the situation. But the fact that Albert spent the time teaching me about the science, and I spent the time learning it, and I spent time educating Albert on what it means to keep livelihoods going, resulted in a better output for Connecticut because we both understood each other's perspective. And that's a big learning going forward. Anytime we have an issue, the science and the economics part have to come together, but both sides have to learn each other's discipline and understand their perspectives to craft the right outcome and the right solution for the state. I have to thank you, though, because while it was tough working with the team, we had an outstanding team that worked with us. The fact that you counted on us to help the state, I think, makes me feel great about the state, feels great about my relationship with you. And the fact that I got to meet Albert Coe through this whole process just has enlightened me in so many ways. I also think that what I really learned through this whole process is what a great team you have around you, between Josh Cabell and Deidre Giffords and David Lehman and everybody else around you, Paul Mounts, Max, everybody. You have an excellent team. No state can be governed without an outstanding governor and a great team. And I think you have proven in more ways than I ever expected that, you know how to govern from the center and do what's right for the state and not get influenced by just the political winds. And it's been a privilege working with you, privilege being a citizen of Connecticut. And you can count on me to contribute in any way that you think I can over the next years. So thank you. Albert, over to you.
Okay, and let me pick up on Indra's words of thanks to you, the governor, for your leadership and that of your staff. I think if there's anything that we've learned, over COVID, whether it's here in Connecticut or in the United States or throughout the world, that governance made a big difference in outcomes, how we came through this pandemic, and I think it's through the leadership of yourself, Josh, David, many others that we did well here in Connecticut compared to other states and certainly other countries. And I'm going to just reflect back down memory lane. It was almost more than a year ago. I remember myself, I got a call while I was in a morgue looking at slides from an autopsy of a patient who died from COVID, and to inviting me to work with Indra. And then the next day, Indra and myself met, at Yale. To really start thinking about, what a plan would be like. And we were called in, this was in April 12th, April 13th, when the Reopening Advisory Committee was convened. And we were called in, this is at the height of our first surge, what we've experienced in the pandemic. And I just remember very vividly, really, this goes back to the idea of the issue of good governance. You came to us with two mandates. One was and what you placed as priority. One was protecting the health of our communities. And then the second was protecting their well-being and their social well-being from the hardships of COVID. And with that, I think, Indra's job and my job was made easy by really setting out those guiding principles about how we're going to address that pandemic. And myself, I can't say enough about, I think this has all been a learning experience for all of us going through this pandemic, but working with Indra and really which captured the importance of evidence policy and implementation. Let me end with just saying, one message. Who are the real heroes in this story? And I think one of the other messages that came out is that public health makes a difference and that we need to continue to invest in it. And we need to not only continue to invest in it, but to do this out of the sense of justice in protecting those who are most vulnerable, not only from COVID, but from all the other diseases that set them up from dying from COVID. And I think the real heroes on this are first, I would say the people from the Department of Public Health, certainly Commissioner Gifford, people like Matt Carter, Jafar Razak, many others who are on the front lines of that public health. And I think testimony is really the advances and progress made in vaccinations and getting to us where we are. And then I think the second is that, your ability, Governor, to really mobilize the people who are the true heroes, which are really the fellow citizens who went through lockdown, who used face masks, who socially distanced each other and kept ourselves safe throughout this last year. So with that, let me hand it back to you, Governor, and with many thanks for what you did for us in the last year.
Well, thank you, Albert. And Indra, I'm not sure you can stick around, and if you can, I appreciate your time here. I thought you loved cricket. I see a lot of baseballs back there. You must be happy that part of reopening includes the baseball season. And I cannot thank you guys enough. Stick around if you can. I'd just like to reintroduce, for probably the 10th time, Scott Gottlieb. Scott is a one-man reopening committee because he has a degree in economics and he's an MD. So he brought a really wonderful balance and somebody I called every time I could. And he had a context about Connecticut, but also the board of Pfizer and Illumina. He had info in terms of genetic sequencing, the variants, the scientific orientation towards where we were on the vaccines, but also a broader perspective, because I was always asking, what's going on in other states? What can I learn? What the heck is going on in Italy and beyond? And Scott always helped me with that perspective. So for that, I'm so thankful, Scott. And what have we learned?
Thanks a lot, Governor. Thanks for the opportunity to be here today and the opportunity to confer with you, and helping keep my Connecticut family safe. I'll just reflect a little bit on where we were and where I think we are right now, and where we're heading. The risk's going to persist, obviously, but I think that the summer is going to be relatively quiescent. I think we're going to have an enjoyable summer with very low infection levels, and we may have to contemplate the virus again in the fall, more likely in the winter, but we're going to be much better prepared to deal with that, both from a standpoint of what we've learned about the virus, the fact that we've got a lot of immunity in the population, not just through the vaccine, but also through prior infection. I think we're going to be in a much different situation in the future, but we'll have to deal with this as a persistent risk. But I think that said, we have a summer ahead of us that hopefully we can get back to doing the things we enjoy relatively risk-free. This is also a population that's more cautious. People are generally more aware of the risk of spread of respiratory pathogens. And I think that's going to bode well for us as well in terms of just our future risk. Reflecting on the past year, we faced a very hard circumstance here in Connecticut because we were part of that initial spring wave when really folks around the country really didn't understand this virus. We didn't have a test in place to be able to detect it, so we couldn't isolate infection. We didn't know how to treat the virus, both in terms of how we approached it clinically as well as the therapeutics we were using. I mean, early on, we were using hydroxychloroquine and famotidine to treat the virus. We didn't have effective therapeutics. And so we got hit very hard, got heavily seeded from infection as a result of our proximity to New York City at a time that we really didn't understand the epidemiology of spread of COVID as well as how to address it. And I think that was reflected in our early experience where we did have unfortunate outcomes in many settings, especially nursing homes. But I think we learned a lot. And as we went forward, the state made a number of, I think, very prudent decisions. When we shut down, when we implemented the mitigation, we didn't shut down the state. We took a very targeted approach and focused on venues and settings that were likely to be sources of spread, and did that intelligently in terms of congregate indoor settings where people would gather in large groups in poorly ventilated spaces. Those were the sources of spread. Those were the super spreading events. That's where we focused the mitigation. It hurt certain businesses hard. So certain people were disproportionately impacted by the mitigation, but a lot of things were left to continue: construction, manufacturing. And so I think from an economic standpoint, the state was able to weather the mitigation, the steps that had to be taken from a public health standpoint, better than many. We focused, I think, on things that were important, like keeping schools open. You and I spoke on that many times. You had almost a singular focus on trying to keep schools and get schools open in the state, and more school districts were open as a result of that, especially relative to a lot of other states. And then when vaccines were available, we made very aggressive use of the vaccines. And I think the early decision to try to distribute the vaccines based on purely on age or largely on age, while we targeted resources into underserved communities to make sure that there was equitable access to the vaccine. I think that was a very prudent decision, and I think it helped us achieve more rapid uptake of the vaccine, and helped us achieve the high vaccination rates that we've enjoyed here in the state. Because while it wasn't perfect, while there's certain downsides to that kind of an approach, overall, I think it was the optimal approach, because it allowed us to implement a regime that could be verified, that could be implemented quickly, where we could get to people quickly. It was equitable to do it by age based on the experience of the virus and where the excess death and disease was. It was in the older populations. It was easy to verify. So, states that implemented more complex regimes to try to allocate the vaccine, I think they had a much slower rollout because of the complexity of the systems that they tried to use, and ended up probably worse off for it in terms of what they were able to achieve and how quickly they were able to achieve it. And we also made sure no shots went to waste here. We took an approach where, we saw every vaccination as a victory, and if a vaccine could go to someone who perhaps wasn't eligible for it at that point in time, but it was otherwise a vaccine that was going to get wasted, we made an effort to make sure that every vaccine went to use. And for all of these reasons, I think that, we're likely to enjoy, a very safe summer. I think that the risk is substantially reduced. The vulnerable population has been largely protected, although there's still always work to do there. And while we continue to face risk heading into probably the winter, more likely the winter than the fall, we still have vulnerable communities here in the state and elsewhere around the country. I think we've done a lot to substantially reduce our risk. So we're in much better shape than most. And I think that hopefully we can enjoy the summer and enjoy some time with our families and enjoy doing the things that are important to us. So thanks a lot, Governor, for all you've done, and thanks for the opportunity to be here today.
Hey, well said, Scott. Yeah, schools did bring us together, and it was, I had called Scott a couple of times, and finally I called him a third time. I don't know if you remember this, and your kid had just been sent home from school, and this thing was really real, and Connecticut mattered, and we were side by side. Can I just ask the three of you, because I'm not sure how long you can stay. George W. Bush got on the aircraft carrier in what turned out to be the third inning of the war in Iraq, and he had a big mission accomplished sign behind him. Are we being a little premature here, or do we think with vaccinations we have turned a corner, and with vigilance we're going to be in good shape a year from now?
Yeah, well, yeah, I'll take that if I can. I don't think we're declaring victory, and I don't think you're declaring victory. I think what we're declaring is an interim victory. I think that we're in as good of a place as we can be given all the circumstances. We've made as good of use of tools that are available to us, both in terms of getting testing widely deployed in the state, making it accessible, getting the vaccine widely deployed in the state, making it accessible early, continuing to make it accessible to people, trying to create incentives for people to continue to get vaccinated. And we'll probably get the vaccination rates even higher around the state. So I do think that this is an interim victory. And I think that the next round of COVID and how we grapple with it is going to look different. The risk profile is different of the overall population. And the virus itself is likely to affect us in different ways. And Albert will probably speak to this better than I can, but we're going to face a lot of risk probably from flu this year as well. So we're going to have the twin risks of COVID and flu circulating at some point in the wintertime, in part because we haven't put a lot of flu into the population. So the epidemiology of flu spread could be a lot different this year, especially if there's a mismatch between the vaccine and the prevalent strain of influenza. On the other side of that ledger, hopefully we're a population that's now more aware of the risk of respiratory pathogens. So at a population level, we're taking more precautions that can mitigate some of that risk, but there will be risks this winter. So I think that we need to continue to be vigilant. And, all my discussions with you, you're focused on those future risks. But I do think that it's reasonable for us to say that we've taken steps and had some shared sacrifices around the state. And Albert spoke to this, all the things that people did, people endured to keep things going amidst all of the risk. We've made a lot of sacrifices to get to a point where I think we are going to be in a position to enjoy a relatively good summer.
Well, that hopefully Scott and Albert can stick around a little bit. Of course, we got Josh, Deirdre, Paul, and happy to take any questions.
Fox 61.
Thanks, Max. Afternoon, everyone. I'd like to ask a question here about herd immunity, and I think I'll address this to Dr. Coe if he's still with us. The thinking a year ago was that we would need to have 80% of our population vaccinated to achieve herd immunity, but that number was really based on the efficacy rates we had historically seen in, say, flu vaccines. And I don't think at that time anyone dreamed we'd have vaccines so good now that our breakthrough infection rates would be at 0.01%. So it seems to stand to reason that we could achieve herd immunity with a smaller percentage of the population vaccinated, just because the vaccines are so good. And so if that's the case, have we achieved some level of herd immunity at this point, or are we at least standing right on the threshold?
Well, thank you for that question. And I think just going back, there are two reasons why we want to vaccinate. Two broad reasons. The first reason is to protect those most vulnerable or at risk from dying from COVID or having severe outcomes from being hospitalized and dying from the disease. And that was the whole strategy with the age-based prioritization of vaccination, to get those to those the high-risk age groups. And really, as the governor said, over 90%. This is really kind of went beyond our expectations about COVID. That we're going to get 90% above coverage above people 65. On the second part is to have transmission blocking, right? That if we can if these vaccines are really kind of home runs in the sense that they not only protect people from getting severe disease, but they also, particularly the Moderna and the Pfizer, are effective in preventing infections and also in preventing people from transmitting one to the other. And so then the question is there a magic number that we reach? And I think Scott, said raised many key issues and key not only key questions but also key responses. First of all, that herd immunity, that's a theoretical concept. It's a concept where everybody is equally transmissible and everyone's also equally, susceptible or equally protected when they get a vaccine. And that certainly doesn't exist. And I think Scott raised important issues is that we may have pockets here in Connecticut, pockets where, there's vaccine coverage rates are lower. And that's where when we go back into the fall or the winter, that transmission may occur. So I think more important than that theoretical concept of herd immunity is getting a vaccine and making sure that we got good coverage for all segments of our population. Now, once we get that, there are a couple things that that are ringers with COVID. COVID's a very different beast from influenza. We have, particularly in two phenomenons. One is it's much more transmissible, but the other is this super spreading, where we have 10-20% of the population responsible for 80% of the transmission. And that puts a little bit of a wrench into that theoretical calculation of what herd immunity is. But bottom line is going back to kind of the meat and potatoes, is that we need to get vaccination out to people, and we need to get good coverage in all segments, all communities of our population.
All right, and then also for you, Dr. Ko, then speaking of the vaccines, what's the latest thinking on additional booster shots for those who've already been fully vaccinated?
Yeah, so this one I'm going to ask for help from Scott. Scott, of course, was Dr. Gottlieb was the former FDA commissioner, has had his hand on the pulse of vaccines, since the beginning. But the first thing is, so we, thinking about where we came from, these trials were started about a year ago, phase 3, these large clinical trials. So right now we've gotten snapshots of how they work 3 months and 6 months out. Pretty soon we're going to be getting data about how they work, up to 1 year out. But it's going to, but I think from what we're learning about, the correlates of protection, what makes these vaccines work, and we're going to be getting a lot of more information in the next couple months. But it's probably my speculation is that these vaccines are probably going to work more than a year going out. Now there's certain threats to those, and those are variants. The possibility of potential to have variants that escape the immunity induced or conferred by these vaccinations. But if we're status quo at this moment, my speculation is that we're not going to necessarily need to contemplate vaccines, at least within a year after initial boosters. But let me hand this over quickly to Scott, for his thoughts.
Thanks, Albert. I have a little bit of a different opinion. I think that what we've seen in the data, both from natural infection as well as from the vaccine so far, and we have data going out 6 months, is you do see a degradation in the level of neutralizing antibodies, particularly in the older age cohort. And so while I think that there's going to be residual protection that extends beyond, maybe a year, maybe beyond, if you're talking about protection from infection, as a result of sufficient level of neutralizing antibodies in an older population, you might be at a point when you're a year out. And remember, many of the people above the age of 65 and 70 were vaccinated probably in January and February. So as they get into, this fall, they're going to be a sufficient amount of time out from the completion of their original series, that I think that there will be an impetus to give boosters, at least to that population, because you're going to want them to go into the 2021-2022 COVID season as they get into December and January and February, when COVID's more likely to circulate at higher levels, with higher levels of protection and not be on sort of the tail end of a level of neutralizing antibodies that provide sufficient protection from infection. You want them to be above 50% protection. And one of the best cohorts for this is the studies of natural infection. If you look at like the Danish landmark study, where they looked at a population-wide study of people who had been previously infected with COVID and looked at the residual protection, if I remember correctly, it was about 80% overall at 7 or 8 months. But if you look at the 65 and over population, I think it was around 47%. So you saw a more substantial decline in neutralizing antibodies for those above the age of 65. There's reason to believe that the vaccines are going to confer a more durable immunity than natural infection, but natural infection should still be a proxy for how our immune systems behave in a setting of vaccination as well. And so if we see a degradation in immune protection in the naturally infected population, we would expect to see something approximate that in the immunized population as well. So my hunch is that CDC at some point in August is going to meet and discuss this and may come out with a recommendation that looks something like, those above a certain age, pick your age, maybe 65, who are more than a certain number of months out from completing their initial series, 7 months, 8 months, pick your time frame, as well as those who are at disproportionately high risk of COVID because of certain medical conditions should consider getting a booster in this time frame, and it'll be sometime in the fall. And the final point here is CDC came out with guidance recently that the COVID vaccine could be co-administered with other vaccines, and so I think that's going to facilitate getting boosters in people. It may end up being something that we can deliver alongside a flu vaccine. When people come in for their flu vaccine, give them a booster for COVID as well. Albert, what did I say wrong? Please correct me. You are well.
No, I think the bottom line is we're going to learn a lot in the next couple months about that. But I think this is probably, we're at a little bit, slightly 1 or 2 centimeters off of a fence, and I'm a little bit more optimistic in the sense that I think one of the things that we never expected is that these vaccines probably work better than usually our dogma was that nothing works better than a natural infection in giving immunity. I think seeing the levels of antibodies that we have. I'm a little bit more optimistic that that they're much higher. But again, I think we're going to learn a lot more in the next several months about that. But
and I agree with you. There'll be a lot more data coming out because you'll have the long-term follow-up. And so far, the data, Moderna's put out some data on looking at the third dose, and the depth and the breadth of the immune response with the third dose look very good. So if we do need to boost, so far the initial data, while small data sets, looks positive.
We'll move along next to News 12 Connecticut.
So Dr. Gottlieb, if you're thinking that people are going to need boosters, are you thinking that everybody is going to need one, or just at-risk groups? And if it's everybody, it's hard enough to get people to get this first round of vaccines. I imagine it's going to be even harder to get them to get a booster.
Yeah, I mean, look, first of all, Albert made really good points, and his judgment is very good on this. So I give a little bit of deference to him. But I think if we do end up in a situation where we're recommending boosters, or CDC makes some recommendation around boosters, ACIP does, I would suspect that it's going to be around a certain cohort, and it's going to be in particular around an older cohort, because if you believe that the experience with the vaccine follows the contours of people who've been naturally infected, even if the vaccines work better than natural infection at conferring immunity, but if you believe it follows the general contours, where you see the decline in neutralizing antibodies in the population who's been naturally infected with COVID is in the older population. They experience a more rapid degradation in the levels of the neutralizing antibodies. And they're also the most at-risk population. So you'd want them to go into the winter COVID season with as high a level of, a safe level of antibodies, neutralizing antibodies as possible. So I think that that's the population that you could potentially be targeting boosters for. And also remember, that's the population that's going to be the furthest out from having been vaccinated. A lot of the, 30 and 40-year-olds got vaccinated in April or March. The people who got vaccinated in January and February of this year or last year, December, very few people getting vaccinated in December, are the older population. So the very population that you want to have maximum protection, and the very population where you might actually see a meaningful decline in neutralizing antibodies to the point where immunity may fall below thresholds that you find acceptable, 50%, 60%, is the very population that was vaccinated the longest time ago. So I could see a situation where you have a recommendation around giving boosters to that population. Final point I'll make on this is that, when we're talking about the difficulty of delivering boosters, if in fact what I just laid out is what we see, that's the population that's also going to be the most motivated to get the boosters. And it's going to be a population that's probably coming in for other healthcare. So we're going to have touch points to deliver it. Remember, probably going into the fall, we're going to be delivering these vaccines in pharmacies and doctors' offices. The companies are working on smaller pallets of vaccines. The storage requirements have improved. So we're not going to need to require people to go to mass vaccination sites. We're going to be able to deliver this more in the community where it's going to be more accessible.
Thanks, Dr. Gottlieb. And Governor, just two questions for you. It looks like the clean slate bill is going to get final approval tonight. It looks like it's going to pass with at least some felonies included. I know that's been a concern of yours. Given the version that's out there now, will you sign that version or would you veto it?
Well, let me take a look at it first, John. I think it just came through. I think they did narrow the scope a little bit, as you pointed out. Those related to violence are probably not included at this point in the clean slate bill. So, and I'm very sympathetic to what we're trying to accomplish, which is once you've served your time, once you're out in good behavior after a period of time, you get a clean slate and allows you to restart your life in a cleaner way. So, I think I'm sympathetic to signing it.
Okay, so it sounds like you would be willing to accept some felonies as long as they're not violent felonies, that sort of thing?
I think that's right, but if you would, just let me take a quick look at the bill first.
Okay, great. And one last question, Governor. Last night you signed the Parentage Act. Can you just sort of talk about, what's that's going to mean for LGBTQ parents and families?
Look, we've got a lot of kids who need a parent, and I think LGBTQ parents and otherwise, it's better to have a parent as a kid. So I want to do everything I could to make that easier. And as with Vanessa Durantes today, DCF, Department of Children and Families, she works with foster kids and foster parents. We need foster parents.
All right, thanks, Governor.
NBC Connecticut.
Hi, everyone. Catherine Loy with NBC Connecticut. I do have a question for Dr. Gottlieb, but I'll start with the governor. You've asked others to reflect on the last year, so I'm going to ask you to look back at the last year plus and what are you most proud of, and then is there anything that you would have done differently in hindsight?
I'm most proud of the team we put together. You got to know what you know in life and know what you don't know, and Indra, Albert, Scott, we had Deborah Birx, we had Dr. Fauci, we had Zeke Emanuel, we had business leaders, we had the Restaurant Association, all the folks you need as trusted advocates to help to explain to people what we're trying to do. So I think that was got us off on a good start. But anybody else want to opine on that?
Yeah, I'll opine, Governor. No, it started with the team, but it also starts with a great leader. And the governor challenged us. He asked questions. He probed us. He made us work harder on behalf of the people of Connecticut. And our results showed. But at the same time, we also took accountability on the places that we could have done better. And we learned a lot through standing up a testing protocol. And then we were able to take those lessons in terms of the testing protocol, in terms of putting together our vaccine protocol. And I think there's no surprise why the state of Connecticut has been consistently top 5 in vaccinations rates. We still have a long way to go, as everybody has said on this call. But I have to echo what the governor said. We have an amazing team, but we also have an amazing leader that we work under in terms of the governor.
And you talk about the testing protocol. Is there anything else that you would have done differently or think you could have done better?
As I was talking to Albert about this earlier, certainly doing everything earlier would have helped, in particular when it came to the nursing homes. We were early compared to our peers in terms of testing and vaccinations and masking in particular. That was the most heart-rending month when the fatalities were there, and we were saying you can't go visit a loved one. I think all of us, if we had a chance to do things differently, we would have addressed that sooner. Not that there were a lot of masks around at that point, not that we were able to do more than 40 tests a day at that point, but if we had the infrastructure to do it, that's what I really would have focused my attention.
Great. And Dr. Gottlieb, first of all, I'm loving the back and forth between you and Dr. Koh. It's clear you guys have a fun relationship.
We're sitting here texting to continue the debate right now. So there's more going on behind the scenes. I don't like to be out of sync with Albert at all.
Maybe you should have a show. But just the speed with which these vaccines got developed, I think at least me, knowing nothing of this industry, was very surprised by that. And it seems like it happened very quickly, possibly precedent setting. Do you think that that's something we'll continue to see with the future developments of vaccines? Will they start to come out more quickly, or will we go back to these long phases of testing to ensure that everything is as safe as it needs to be?
Yeah, it's a great question. And I don't think that the question here, the speed, was because we did anything to short circuit the testing. And as you know, I'm on the board of Pfizer. There were two places where we made up time with respect to the development of this vaccine. One was that we came up with the vaccine construct very quickly, very efficiently. And the reason we were able to do that was because we have now entered the age of fully synthetically derived vaccines, being able to derive a vaccine construct off of sequence alone. The old way of making vaccines was you isolated the virus, you figured out how to grow it in cell culture, you grew it in cell culture, you inactivated it, and then you put it into a syringe and made a vaccine that way. In fact, if you watch the movie Contagion, which I did recently, the sticking point in them being able to get the vaccine in that movie was their inability to grow that virus in a cell culture. They couldn't find a cell culture that it would grow in, and they finally found one. It was a fetal bat cell culture in that movie. That's usually been the stumbling block. And in fact, in 2009, one of our stumbling blocks getting the H1N1 vaccine to scale was that we couldn't grow it with sufficient yield in the cell cultures we were using in that time, chicken eggs. Here, we were able to come up with a construct very quickly, and because it was synthetically derived, we were able to put it into manufacturing very quickly and manufacture at scale. Once we got that manufacturing in place, that manufacturing didn't exist. We didn't have to wait to figure out how to grow it in a cell culture. The other place where we saved time is we didn't do all of the long-term stability studies you typically do with a vaccine to make sure that it could be stored in a refrigerator for 10 months or 6 months or 6 weeks, and in a normal refrigerator for 6 weeks, and then on the shelf thawed out for a couple of weeks. Normally, you would do all that stability study work. That could take years. Instead, because we were in such an urgent situation, we basically froze the vaccine as a subarctic ice cube and put it into the market, distributed it, knowing that it wasn't going to have to sit at all. It was going to go to mass vaccination sites. We were going to distribute it in large quantities, and all of it was going to get distributed. We didn't have to put it in a normal supply chain where it would sit in a doctor's office for 6 weeks, so we didn't need to do the stability studies. So now we're doing them, and that's why you see data coming out saying, well, we can keep it for 6 weeks after all. We can keep it in a refrigerator for longer than we thought. It's because we did those studies after the fact. Where did we not save any time? We didn't save any time on the clinical development. We did full-blown outcome studies where we looked for outcomes, the outcomes being, getting symptomatic COVID, in some of the largest studies ever undertaken in the history of drug development. The only study that I remember that was larger than the COVID studies was the rotavirus study, which was about 60,000 patients. But collectively, these COVID vaccine studies were each 45,000 patients. These were enormous outcome studies, but they went quickly. And why did they go quickly? Because they enrolled fast, because people were motivated to get into these trials. And unfortunately, they read out fast. And I say unfortunately because the endpoint in these studies was people getting symptomatic COVID. And there was so much COVID infection around the US and South America where these studies were being run that a lot of people in the placebo arms of these studies got infected very quickly. And so we had a readout earlier than we expected. And that's the part that matters the most to determining the safety and efficacy of the vaccines, is that clinical development. To sort of sum up with the answer to your question, if we're able to develop other vaccines in the future through these fully synthetic processes, and I think we will be, we were right at an inflection point in science where we had these opportunities. Pfizer had been developing a flu vaccine using these techniques. Moderna had been developing a number of vaccines using these techniques. We were right at an inflection point in science. And I think going forward, we're going to see more vaccines be developed using these fully synthetic techniques. If COVID had struck 2 years ago, we would have had to go the old cell culture route, which is what China did. We probably would have ended up with vaccines that didn't work as well. If COVID had struck 2 years from now, I think these techniques would have been mainstreamed, and it would have been no question we would have used these approaches. We were right at a scientific inflection point.
Hey, Scott, I just got to say, imagine being married to a former FDA commissioner. It's a Saturday night. What do you want to do? I know. Let's watch the movie Contagion again.
Nobody watches it with me. I watch it by myself. No one wanted to watch it with me.
Channel 3 Eyewitness News.
No.
Yes, Governor, I'd like to ask about food supply. You know, last year at this time, tens of thousands of people were driving up to get bags of food. What are those numbers like today, and how much of a bellwether is this for the state as we look at the Connecticut comeback?
Well, I'll start with that and then pass it to Josh, which is my habit. First of all, I think if we've realized one other learning lesson over this last 14 months is supply chain. And, you know, that was masks and on the phone to China, and that was vaccines and where that's coming from. And that was also food. And for a while, we were worried. There was some hoarding. There was, some scarcity in some of the shelves going back about a year or so. And I think we realize sort of the importance of Connecticut Fresh, at least having some of our own supply that we know we can count upon, and I'm really proud of that. I think you find out that we do continue to have food insecure people, even now as our economy is coming back, or people are coming back to work, and that's going to probably keep going a little bit longer. Certainly as long as you have, COVID hesitant people who aren't sure when they can get back to work safely. Josh, anything to add on that?
No, I think you said it well, Governor. I mean, I think what we're seeing right now is a transition to this new normal, where some of the extraordinary measures and structures that were put in place, whether it was around food distribution, mass vaccination, mass testing, and others are being decommissioned, but it doesn't mean the need has gone away. And I think when you look at the governor's budget proposal, his recommended allocation for the funding we're getting from the American Rescue Plan Act, it's really focused on those areas of need where we still see tremendous need in the community, people who are disproportionately impacted by COVID, where there's still significant unemployment, significant hardship, where the governor is focused on trying to get additional resources in to help those people.
And I'd like to end on this question here. It relates to the governor's message yesterday of just getting out of your house. And while the state and science says it's okay, especially for vaccinated people, we're still seeing some people who really aren't sure how to navigate our reopening. Dr. Gottlieb actually mentioned that we do have a more cautious population here in Connecticut. So how do you convince them to get comfortable going back to normal?
Well, I'm going to take a first hack at it. I think time is convincing people. Just because we flick a light switch and say restaurants are open doesn't necessarily mean everybody goes pouring back in. You know, people are getting cautious. They talk to their friends. They get some confidence. They see the restaurant is paying attention to the protocols. They have some confidence that the people not wearing masks have probably been vaccinated. So I think slowly people are building confidence to get back, and I think that's a good thing. Anybody else?
I'll just echo that, Governor. I think two things. Number one, we've spent a year apart. We've spent a year taking a lot of precautions in terms of our interactions with people. And I think for some people, it's going to take time to reacclimate to settings where we feel that there could be some residual risk, even if our individual risk is very low because we're protected through vaccination. And so I think that, certain people are going to need to reacclimate to those kinds of social settings. I think there's going to be situations where people, even who don't feel that they're at risk, still put on a mask because it's etiquette in certain settings. I still put a mask on when I go into the grocery store or the pharmacy, not because I feel I need it. I feel I'm well protected. But there's a lot of people wearing masks in those settings, and I want to show respect to other people who may feel uncomfortable being in a setting where there's unmasked people. And so I've still been doing it. I think that that's going to persist for a time. There's a certain social etiquette that's been adopted. And then I think there's going to be people who, we need to make judgments about our individual risk. And even if our risk is low, for some people, even a low risk may be an intolerable risk, or a risk they don't necessarily want to take if they could take measures to mitigate that risk further. So there may be people who are vaccinated, and we scientifically judge them to be at low risk, but they want to take extra precautions, and so they might wear a mask. There might be people who are at higher risk because the vaccine doesn't work as well for them, or they've decided to forego vaccination, and they're going to wear a mask and they're going to take added precautions. I think this is going to be a very personal decision. I think we're getting to a point where the decision making is no longer going to be guided by policymakers. It's not going to be a consequence of public health authorities issuing edicts or mayors or governors. The decisions we make about how to protect ourselves are going to have to be personal decisions that we make based on our own assessment of our risk and what we're comfortable with. And that's going to evolve over time.
Thank you very much.
News 8.
Hey, Governor, some essential workers are looking over the past 15 months and feel like they are grossly underpaid right now. Group home workers are now demanding a $20 an hour minimum wage. Do you support that, and will you help make that happen?
Well, look, we reached a really good, strong agreement with the nursing home, the nurses there who are frontline essential workers every day. I know Paul is leading the discussions in the group homes as well. We're going to hopefully find a similar type of resolution there as well. And more broadly speaking, I can just tell you, I think you have to start paying essential workers a little more across the economy. You know, people are saying, oh my gosh, people are hesitant, they're not going back. I think sometimes you're going to have to incent people a little bit more right now, especially when we have some labor shortages. So I think that's a good thing.
Are you willing to put out a dollar amount when you say being paid more?
I don't think so. As you know, look, we took the lead as a state in terms of a $15 minimum wage, sort of recognizing the value of work and making sure that work pays. And we're getting to that number over the next year. And I think a lot of nurses and healthcare workers and food service workers and folks who are essential workers on the front line, putting themselves out there every day during the peak of COVID, they couldn't telecommute. They will be getting a raise.
And a little off COVID here, I know talks are progressing on the recreational marijuana bill. If the legislature votes in favor of this, how soon could residents see storefronts opening up?
Well, we're going to have to put in place the regulatory infrastructure, which Paul can talk about a little bit. But I'd like to think, I see what's going on in New York. It's going to open in about a year, year and a half. Maybe we can do a little faster, Paul. What do you think?
Yeah, we're looking at we've seen the timelines that's happened in surrounding states, and of course we would like to move swiftly as quickly as we can. But at the same time, we want to make sure we get the regulations right and go through the proper processes for that. So as the governor said, we're looking at that very much of a similar timeline as the governor stated. But at the same time, you still need a bill. And so the negotiations are still ongoing as it deals with that. We have a few days, few weeks left in session, but the time is of the essence. I know the conversations and negotiations led by our negotiating team as well with the legislature has been fruitful, but at the same time, time is moving by fast. So can't really talk about setting it up and getting it forward until you actually have a law that will allow it to happen.
And Governor, do you look forward to taking advantage of recreational pot?
Time will tell.
All right, thank you.
The Associated Press.
Good afternoon. This might be for Commissioner Gifford. I was wondering, is the Department of Public Health tracking the issues that people who had COVID may still be having, people that are suffering from long-term health problems? And if so, what are we seeing?
We're not formally tracking them, Sue. We have certain things that are mandatory to be reported to DPH, and COVID infection is one of them. But we don't really have a formal mechanism at this point of tracking the longer-term outcomes. So we'll be, working along with scientists and researchers in the CDC who are looking at this issue nationally to see what we might expect here in Connecticut.
So this isn't like an adverse effect or a problem that physicians have to report to DPH?
It's not really well defined yet, so it's not something that we could easily make reportable at this point in time. If it becomes something that's a clearly defined syndrome, then that might change in the future. But at this point, it's still sort of a collection of symptoms and not an easily defined set of symptoms that we could collect data on.
Thank you, Doctor. And I'm not sure, maybe Governor or someone else might want to respond to this, but researchers at Johns Hopkins have said that Connecticut ranks 7th per capita in COVID deaths. We've got 8,230 people who died. How do we square that with the state's success?
Well, I'll start, and then we were hit hard. We were hit hard, very early. And before anybody knew anything. And the Surgeon General is up here saying masks transmit disease and hydroxychloroquine is a miracle cure. And we were making the best information. We were making the best decisions with the limited information we had. But I think the answer to that, Sue, is we were hit hard early and we learned quickly. And you'll see after that surge, you remember from that chart Max showed you earlier, we outperformed over the course of the next 10 months, thanks to a lot of the folks on this meeting today. Anybody else?
Yeah, I mean, I would just echo that. I think that the country really had two experiences with COVID. One was that first wave of infection in the spring when we were unprepared as a nation. We didn't have testing in place. We didn't know how to treat COVID. We didn't understand the epidemiology of spread. And then the period of time after that. And if you look just at the data on mortality, we probably, by the end of the summer, we probably have had cut the case fatality rate in hospital mortality in half. Just not even through the introduction at that point of new therapeutics, but through advances in care. We didn't intubate as aggressively. We started to anticoagulate patients, and so we saw fewer deaths related to blood clotting. Doctors early on, and Albert was on the front lines of this, so I'm going to turn to him, but doctors early on were describing situations where patients would suddenly decompensate and need to be intubated urgently. They probably had blood clots that were going unrecognized because at that point we weren't doing PE studies. We weren't, the guidance was not to do a lot of procedures because procedures could lead to in-hospital spread, so we weren't looking for the blood clots. Then we started to recognize it and started to put patients on blood thinners. Early on, we weren't hydrating patients aggressively, and a lot of patients were going into renal failure, so without hydration would increase their oxygen requirements. So there were all kinds of things we were doing just from a clinical practice standpoint where we really innovated very quickly in clinical practice and substantially reduced in-hospital mortality. I think the early experience was reflective of a period of time when we were in a fog of viral war and didn't understand how to treat it, didn't understand how to diagnose it, didn't have the tools to diagnose it, didn't understand the epidemiology of spread. Albert, you were on the front lines there, so.
Yeah, no, I think, Scott, I think you're spot on really what happened and how clinical care improved over time and how that made a big difference and how unfortunately, fortunately, the rest of the country learned from the experience, not only here in Connecticut, but, all of the Northeast got hit hard. I think there are two other things that kind of put us behind the eight ball. One was, of course, as Scott and the governor said, that we got hit hard first. I think the second is that our population is older, many times older than other states. And the third is that initial surge, like 60%, 65% of all the deaths were from nursing homes. But going back to what Scott and the governor had said, is that there was a lot of learning, and that learning happened really quickly at DPH. And I think the best example is the nursing home outbreak. We had a horrendous initial nursing home outbreak, but then when the second wave came in November, the death rates dropped, the mortality in that population dropped more than 7-8-fold. I'm not sure exactly the number, but there are much fewer, significantly fewer deaths that happened in that vulnerable population. So I think that kind of captured our experience that we got hit hard early, but reacted very quickly, and really went through agonizing. And Josh was key in this process. Josh and Deidre, kind of hand-wringing and lessons learned in May and in June. To prevent anything that would happen, in March and April from happening again in the state.
I'd just add to, I think it's been pretty well documented at this point that a lot of states have been undercounting their COVID deaths. Connecticut's one of only, I think, 10 states that includes probable COVID deaths in our totals. A state like Florida has had a very mysterious, significant spike in pneumonia-related deaths over the course of last year. So there may be some classification issues and so forth that can settle out. We've tried in Connecticut to be incredibly transparent, share all the data that we have, confront it, deal with it. But when you compare across states on a metric like that, it may not be apples to apples.
Thanks, and I appreciate you guys taking my questions all these months. Thank you.
The Day of New London.
Hi, everyone. Governor, I know the mission isn't permanently accomplished, but since we're looking back with a wide lens, what do you think are some of the most prominent lingering problems for the state caused by the pandemic?
I think, from a health point of view, I do worry that some of our populations are under-vaccinated, and I think that's a risk to them, a risk to their community, and a risk to the broader community, if you would count that as a lingering problem. I think economically, we still have some healing to do, and I think psychologically we have some healing to do. There are a lot of folks who are terribly hit hard, isolated, alone, kids who have not been back in the school for many a month, and that's going to take a while.
Thanks for that. One more question for you about the budget. We've talked a lot about disagreement over taxes. Where do you think you and the legislature differ on spending? Are there legislators who want to spend more on paying down pension obligations, for example?
Look, I can work. We've got a budget in place with our internal growth as well as the American Rescue Plan. Spending would be up about 20%, so there's less debate about that. I like to keep things within the confines of the spending cap, which I think is very important, something the legislature voted on just 4 or 5 years ago. I think in terms of priorities, we have broad agreement in terms of what we have to do to focus on those folks who have been hit hardest by COVID. I'm pretty confident we're going to be signing a budget in the next couple of weeks.
Thank you. I appreciate it.
CT News Junkie.
Thanks, Max. Governor, I had a health insurance question for you. How do you plan to expand access to health insurance that's affordable for small businesses and nonprofits? You said lowering the cost of health insurance was a priority following the 2019 session.
Yeah, two answers to that, Hugh. For the very smallest businesses, they may find we can create an account where their folks go on the exchange, which, as you know, costs there have been dramatically reduced. And if we have our way, we're going to have an additional supplement provided by the state that's going to reduce co-pays and deductibles quite a bit. And secondly, I'm really happy that we've got, I think, not one but two new platforms on the exchange, one from Cigna, one from Anthem, that are going to be focused on small business, both of which provide a significant discount compared to what they're paying right now. So we're making progress.
Okay, thanks. A question, too, on capping drug prices. The pharmaceutical industry says that would cripple research and development, and they're also saying that the similar proposal you were talking about in Massachusetts, I think, has stalled or failed there.
Well, I'll start with that, but I don't want to duck it. So I've got a guy named Scott Gottlieb who knows some about this as well. Scott, I was working in conjunction with Charlie Baker in Massachusetts, as Hugh alluded to, where we've got a fair number of drugs, not all of them, but in some cases a lot, that go up much faster than the rate of inflation. So my case was, look, you get that initial price, maybe you're regulated by the FDA, you get a good rate of return on what you got to do, but over the next 10, 15 years, and then you go into the generic category, maybe we do that at inflation plus 2%, unless there's some real change in the nature of the medicine or the manufacturer that would affect that price. I thought that would hold down underlying healthcare costs and give folks who maybe need an EpiPen a little more predictability in terms of those costs, but don't hold back. Scott, would you like to comment on that? You know some about it.
Is he still
Oh, I said I was going to let you have the last word on that, Governor. I'm sorry, it's on mute.
I don't want to put you on the spot, but you're quite knowledgeable on this.
Well, look, you and I have discussed this many times. We've certainly seen situations where companies have taken excessive price increases and that don't comport with the value that they're delivering to patients. There are circumstances where the price increases reflect certain scarcities, certain challenges getting drugs into the market, particularly when you're talking about, for example, injectable parenteral drugs, injectable generic drugs, where there's been chronic shortages because of underinvestment in manufacturing, where sometimes the ability to take a price increase is something that's a self-corrective action in the marketplace to get more supply into the market. So I think, when we talk about inflation caps, and this is obviously being contemplated also at a federal level, so what the state did really is reflective of what's being discussed in the Senate Finance Committee as well, and may well pass federally. When we talk about inflation caps, I think it becomes really hard from a policy standpoint to carve around the circumstances that are desirable, where a price increase may be necessary in order to get needed competition in the market. Maybe a self-correcting short-term price increase actually is going to lead to more competition that's ultimately going to get more supply, get more reliable supply, bring prices down in the long run, versus those undesirable circumstances where we can all agree that we've seen excessive price increases around drugs where, entrepreneurs or speculators are just playing an arbitrage and coming into a market and jacking up the price that doesn't really comport with any measure of any additional value that they're delivering. I think from a policy standpoint, it's hard to it's going to be hard to carve around the sort of understandable circumstances and to get at the undesirable circumstances.
Thanks.
Okay, thank you, guys.
The Connecticut Mirror.
Governor, the numbers on the vaccination rate among blacks is both, you noted, is both good and bad. Connecticut is at the top, near the top, but yet it still lags badly. So is there anything new that your administration is going to attempt to change that? Obviously, there's no problem with availability of vaccine at this point, and I believe, certainly access is greatly improved. So I guess the bottom line question is, what do you do now to improve that?
That's a pretty good question, Paz. I mean, obviously we focused on access, make sure it's readily available. We're now taking the vaccines right to you. We've really got home delivery at this point. We focused hard, as you know, on trusted advisors and advocates who can speak to the community, be they clergy or otherwise going forward. And Josh and I are always trying to think about incentives and ways to get people who maybe aren't opposed to vaccines but just haven't gotten around to doing it, to give them a little more confidence, a little bit of a nudge. But Deirdre or Josh, do you have anything you'd like to add?
I think the answer is that we're going to keep going, and we're not going to let up until everyone has their questions answered, everyone has the information that they need, everyone knows where and when they can get a vaccine. We're going to keep asking the question of our partners in the community, what do you need that might be different from what we've already tried? As the governor mentioned, we keep working to find more trusted messengers in the community who can get this message out for us about the importance of vaccination. And I keep providing information. What we're learning is that people want to hear from friends and family and neighbors and colleagues, trusted individuals in their own community. And so the process might be a little bit slower, but we're going to keep on trying, because this is a real priority for us, for the department, for the governor, and for the state.
The other part of it is we're going to keep innovating, right? We're going to keep learning from what works, what we can learn from other states. We're experimenting. One example is, we've had canvassers out knocking on doors in under-vaccinated communities. The yield's been okay. It hasn't been great. So we're going to pivot some of those canvassers to go where people already are, at crowded stores, at bus stops, at events, and go person to person at those events and talk to them there where they're already gathered, rather than go door to door. And we're starting to see some early results from that. So it's just an example. We're going to keep at this all summer, all fall, as long as it takes, as Commissioner Gifford said.
And the other thing that jumped out on the map was Eastern Connecticut, where there seems to be a political aspect to that. That was the part, if you overlap that map with where President Trump did the best, you're going to see low vaccination rates. So is there a special challenge on how you address that when the issue is one of politicization as opposed to perhaps just general concerns about a new vaccine?
I think what the research nationally is starting to show that many of the people who are reluctant, maybe slower to get vaccinated than some others, still are open to thinking about vaccination. And it's a fairly small proportion of the population that are a hard no. So there's more information to be shared. We need to make sure that that the issues around trust and safety of the vaccine are fully addressed, and that we're transparent about, what potential side effects of the vaccine, and that people continue to understand their safety and effectiveness. So this is a matter, again, of repeating information, making sure we're reaching people, understanding what their questions and concerns are, and then making sure that the vaccine is available in their communities in a very convenient way. And so we're just going to keep on doing those same approaches. I want to add another thing to what Josh mentioned, which is that we've pivoted some of our contact tracing resources out to be community ambassadors. And we started in this week in some of our high SVI communities, having them in high foot traffic areas like grocery stores and pharmacies and department stores, making sure that people that are there shopping, that maybe were on the fence about getting vaccinated, they could answer their questions and then direct them right to the walk-up vaccine venue in that store. So that's a new process that we just started this week, and we'll see how that works and then keep on innovating after that.
And Dr. Gottlieb, I have to put the question to you as well. What should the Trump administration have? Is there anything the Trump administration could have done early on, perhaps, to nip this in the bud? The idea of that this became, again, more of a political belief among some populations.
Yeah, I mean, it's hard for me to reflect on what the Trump administration did or didn't do early on, because remember, there wasn't a lot of vaccine available for the duration of the Trump administration. So there really wasn't a broad rollout of the vaccine until much later, just because the supplies weren't there. I think that this has been something more fed on social media and in certain channels. I think it's not just purely political. You cast it in sort of political terms, Trump voters versus Biden voters. I think it's also somewhat cultural. I think it's a view that the vaccine is something that's being offered and administered by the government. So people who might have some concerns or aversion to something that comes through the government, or the vaccine is being used to arbitrate access. And so people who may see the vaccine as a tool to either deny or supply liberty may have some aversion to the idea of getting vaccinated for those reasons. So I think it's more cultural or political lowercase p as opposed to political uppercase p. And from my standpoint, just gets back to the question of, how do we get more people vaccinated? I think we're going to get more people vaccinated by recognizing that we've worked off the sort of the robust demand for vaccination, and people who are sort of easily available customers. They were eager customers. And now we're getting into softer demand. We're getting into people who have longer consideration periods. They need more information. They have more questions. We're getting into people who don't see the same value in getting vaccinated, maybe because they're at lower risk. So they're making an informed judgment. I'm not as at risk. We're getting into people who see the vaccine perhaps as, a sort of tool that's going to be used to potentially deny them access to certain things, the idea of vaccine passports. And so they have, some suspicions and hesitations around it on those grounds. And that gets into the political arguments you discussed. And I think the way to get more people vaccinated is going to be to try to reach each of those groups with information and messages that they find seductive. And so, just to give you one example, I've talked to a lot of people who say to me, I'm 40, I'm 30, I'm healthy, I'm not at significant risk from COVID. Why should I get vaccinated? And the answer there is that one of the answers is that by getting vaccinated, you're going to substantially reduce the risk that you can become someone who's infected and goes on to infect other people. That if you're around young kids or you're around older individuals who you want to protect, if you're vaccinated, you're going to be protecting that individual that you care about. And a lot of people find that a very valid reason to go get vaccinated, even if they don't feel they're at personal risk. They feel that if they can go get vaccinated, and that can substantially reduce their risk of being an individual who introduces the infection into a setting where there's people who are vulnerable who they care about, that's a reason to get vaccinated. So we need to find ways to appeal to people, with the information and appeal to their values in terms of why they would seek vaccination.
Thank you very much.
Connecticut Public Media. The Hartford Current.
Hey everybody, this is Emily Brindley from The Current. Governor, a question for you. So I've noticed obviously in the past couple of days that your tone has shifted considerably on the risk of COVID. Yesterday you told people to get out of the house, and then today obviously with the final press briefing. I'm wondering, do you have any concerns that regardless of how you personally feel about where we are in the pandemic, do you have concerns that these will be signals to residents that the pandemic is over?
I think there's signals to residents that what you've been doing has worked, that the masks worked and no longer is necessary now unless you're unvaccinated indoors, that vaccinations have worked. But hopefully, Emily, it's a reminder that if you're not vaccinated, as Scott just said so eloquently, it's not maybe a matter of your own risk because you're a relatively healthy 30-something, but those young people that you may be in contact with or an older person who's immunocompromised. So I'd like to think that we've got a good balance going forward, and but people in Connecticut have been pretty smart about getting that balance.
And on a similar note, this press briefing has read to me as at least a bit of a celebratory tone, where we have a lot of people talking about the pandemic in the past tense. I have Twitter up right now, and I'm seeing people online in Connecticut also doing the same thing, talking about the pandemic in the past tense. So how do you kind of square that with the high number of people who still aren't vaccinated? We have more than 1.3 million people who aren't vaccinated. How do you encourage people to go get vaccinated if there's, the state is open and there are signs to them that we're in a good place already?
Well, let me pass to the other guys. I tried to answer that. Look, I'm the guy that said no mission accomplished banners. We got to be very vigilant going forward. We got schools and things we want to get open. A lot easier to do that if everybody is vaccinated. So, Josh and Deirdre talk about the emphasis we're doing, the outreach we're doing, making sure people know the reason you're outside, the reason we're having fun, the reason you're able to go to a restaurant is because people have gotten vaccinated and it works.
And then one last question for you there. You mentioned the continued vigilance. Can you talk to me a bit about what form that vigilance is taking when the state is fully reopened?
Well, one, we're going to look at the metrics, and we're going to make sure that when it comes to infections in those less vaccinated areas, we're on top of that. I think working with people like Albert Coe and Scott Gottlieb, we're going to keep a close eye on India, a close eye on Brazil, and places where variants may try and sneak back into this country, and they may find fertile nesting in some places that are less likely to be vaccinated. I think we're going to watch that very carefully for the foreseeable future.
All right. Thank you, everyone. Appreciate it.
Hearst, Connecticut Media.
Hey, Governor. I wanted to follow up on the negotiations with the group home workers. What's the likelihood of a deal? And would there be increased funding for the nonprofits that run the homes?
Want to take that, Paul?
Yeah, no, you got to understand the conversations happen directly with the group homes as well as the unions, make sure everyone's get back to the table. As you know, from the nursing home situation, there's a role that the state has to play both on the budgetary side, but also the preparation side if the strike notices are not rescinded. We always remain optimistic because we are at the table. We are talking to people. We're cordial. We understand their concerns, and we are direct and honest. So we have a budget process that we're going through. In the midst of that, Melissa McCall and her team at the Office of Policy and Management, as well as the rest of our agencies that are affected, are crunching the numbers accordingly. And we will be we're confident that we can get to the right place on this situation.
Thanks, and then this may be one for Josh. Can you say why the state waited to publish the data showing neighborhood by neighborhood vaccinations, and then looking at the disparities there? How much is it the state's issue to track down those under-vaccinated neighborhoods, or is it more on local health departments? What's the split?
Well, we have the data published at the census tract level on the open data portal, so anyone can go take a look at that. But it's, as it always has been, it's a partnership, right? The state working with our local partners, bringing the resources to bear to do the work, the hard work, as Dr. Gottlieb mentioned, that's in front of us at this point, to get out to the remaining people who have not been vaccinated. And that partnership at the local level will continue.
Thanks. One more. Governor, on the issue of the public option that would allow small businesses and nonprofits to buy into the state-sponsored health insurance program, we know you don't want to expose state taxpayers to as much as $50 million, but aren't you concerned that in the middle of the pandemic, the Connecticut-based insurer is paying its CEO $79 million? Are you concerned about that at all?
Well, yeah, that doesn't make my day, but I think that is less relevant to the discussion. What is the most impactful way that I can expand access to health care at the least cost to the people of Connecticut? And we've come up with a plan leveraging off of the help we're getting from the federal government, great expansion of the exchange. We have a thought in there about how with an additional $50 million we can get rid of the co-pays and the deductibles for I think everybody earning up to $60,000 or so. I think we've got the best way to expand access, and I think one of the many lessons we've learned is the broadest expansion of access to health care to everybody. It's not just a basic right for you, but it's really keyed to the safety and public health of the greater community.
Thank you.
The Waterbury Republican American.
Thanks, Max. I have a question for Dr. Gifford. You know, as an epidemiologist and the acting public health commissioner, what are your biggest concerns as we try to manage what could be the final stages of this state outbreak?
Our biggest focus right now is on getting everyone vaccinated. And as you heard many speakers say this afternoon, the biggest risk we face as a country is that in places around the world where there are lots of infections, unfortunately, still happening, we have variants that could potentially break through our very excellent vaccines in the United States. So it's important not only that we get everyone vaccinated here, but that there's a concerted international effort and the world turns its attention to getting the pandemic under control worldwide. So in Connecticut, we need to focus on making sure that every individual who is eligible for vaccine has the information that they need, have easy access to an appointment and vaccination, and that we don't leave any stone unturned in getting people vaccinated. As the governor mentioned, we're going to continue at DPH to watch our numbers every week. We're not going to stop measuring COVID cases or tests or deaths or hospitalizations. We're going to keep looking at our vaccination rates very closely by down to the block level, as we were just talking about, and we're going to continue our outreach with communities to make sure that people know where the vaccines are still needed and that they know how to get them.
And speaking of the variants, I did some quick math, a while ago anyway. It looks like that's slow, at least the identification of the variants is slowing. I think there was 322 an increase of 322 in the past week. And when I looked at it in terms of the cases since January, it's about a little shy of 5,800 cases variants, and that's about 3.5% of the reported cases since January. So what's the sense of the spread of variants in Connecticut at this point?
Well, as you know, we haven't been systematically testing a regular sample of our positive tests with whole genome sequencing since the beginning. So what variants we know about have been reported to us by commercial labs. Our laboratory director, Dr. Razak, has been working on standing up a process by which we will systematically test positive samples in Connecticut and make sure that we are tracking and know what variants and how many variants are present. So we'll have a much better sense going forward when that system is in place of the percentage of our positive tests that are variants and what type of variants they are.
Okay. And Governor, I've gotten another reader question. I know you've answered this several times, but could you perhaps just reiterate why you aren't joining other governors in halting the additional $300 federal weekly pandemic benefit for unemployment?
Yeah, because it halts by itself in, I think, a little over 90 days, Paul. B, there are an awful lot of people that are just still worried, as you heard, about going back to work given COVID, given the COVID hesitancy. Give them, if they need a little more space. A lot of people are having a hard time finding a job, although you're absolutely right. There are a lot of jobs that are going begging right now, and that's why we did put in place the $1,000 incentive to help those people who are a little hesitant, need that nudge, and make it a little easier for them to afford childcare, make it easier for them to afford transportation so they can get back to work. That's the priority, get everybody back to work.
Okay, and in terms of, I know you said yesterday there were like 1,000 inquiries, I think, to the website on the $1,000 bonus. Can you give us any update on that? How many people have applied? Maybe how many people have qualified, if anybody has? I was just
well, you can't apply until you've taken the job and you've been there for a couple of months. So what we have, though, is now well over 1,000 people who obviously are interested in the nature of the incentive. Let's see those turn into jobs, and let's see them turn into long-standing jobs.
All right. Well, that'll be it for me. And again, I'll join some of my colleagues in thanking everybody who's been participating and taking our questions and helping us explain to people what's going on.
Well, believe it or not, we're getting the signal. This has been our marathon session. Albert and Scott, go home. You can go watch Contagion again if you want, Scott. But I owe you guys a real debt of gratitude. We really needed you, and you were there for us. And that goes more broadly to our team. I got to say, I was just with General Evon, and he said, it's been a heck of a year, Governor. And for the first time in a long time, we have a few hundred of our Guard who are able to stand down, spend a little more time with their family, take some of the courses they weren't able to do before. As you know, just as part of the team, they took care of, all the PPE, stockpiling that. They were there for a lot of the testing. They were there for a lot of the vaccination work. It's just an example of the breadth of people who got so involved. I got Deirdre, to you, I mean, you were doing double duty. You had public health as well as social service. And to you and your entire team, I was so moved that day. I went to public health, and I saw everybody lined up, ready to go help out at the nursing homes as needed. I hope they know how incredibly thankful I think the people of Connecticut are for the work they did. And Josh, you and Deirdre had a sort of similar relationship. We had, the scientific and the management, and you were there from the very beginning on behalf of DAS, helping us manage through this. You and David Lamont, we had to work with the business community, had to set the protocols in place that made sense so that when people went back into the restaurants, they knew they could do it safely. And we did that in association with the businesses themselves. This was not a conflict. This was something we were able to work on, together. And Albert, to all the folks that are on your scientific team that you put together, there were dozens of them, and the hours that they put in, taking advantage of the most amazing healthcare system in the country we've got here in Connecticut, we were able to advantage, and it was really beneficial for us. That reminds me, the first people we reached out to, of course, were the hospitals. And we worked hand in glove with the hospitals. They're the front line of defense when you have an attack. And it was an attack. It was a COVID attack, marching right down the Metro North corridor there. Hospitals working very closely. Reg Eady from Trinity, he was their co-chairperson of the vaccination team with Deirdre. That was invaluable for us. I just want to say, on a personal note, I'm in this room. We've been sort of distant for a long time. I'm here with the folks from CTN who have been standing up, unfiltered, giving us an opportunity to explain as best we can, some tough decisions. I mean, you heard Albert and Scott going back and forth. These are the things that you have to decide along the way. So the folks that And by the way, over here we have a signer. I'm curious to see how she describes me describing her as a signer. I'd like to see how you sign hydroxychloroquine. I've always been wondering about how that works, but just the message you've been getting out, you and your friends helping us here, I think are invaluable. And more broadly, the media, we have our moments, but we really needed everybody to stand up. There was more darn misinformation and more rumors going out there. And you've been on these calls. You've been on for now close to 2 hours. You've been getting the information out in a way that counteracts a lot of the misinformation that's out there. I'd say the same thing for the legislature. Look, let's face it, democracy is pretty messy a lot of the time, probably even most of the times. But when we get our back to the wall, we do pretty well as a country and as a political system. And I want to thank the legislative leaders and the legislature in general on both sides of the aisle, what they did. I saw what was going on in other states, and we hung together, for which I'm very thankful. Let's face it, Washington, we got the resources we needed, so some thanks there. And finally, we talked about the essential workers. That's not just nurses and docs, that's food service workers. To each and every one of you who stood up, we have a new appreciation for the work you do. And finally, just to the people of Connecticut, we did pretty well as a state. And I think we did pretty well as a state thanks to a lot of you. Thanks to the overwhelming majority of you. I mean, we were more likely to wear a mask. We were more likely to stay a little closer to home. And more likely to get vaccinated than just about any state in the country. And that's making an enormous difference. We're not rolling out the mission accomplished banner, but it's thanks to you that we're able to make the progress we can, the opening we can, and getting back to business. So this is the last of our formal COVID advisory meetings, but we'll be having updates along the way. But with that, thanks to everybody who's been on this call for close to 2 hours.